Yes, sir. She has joined, sir. She's here.
Yeah. Good morning. Today we will have two journals of presentation. The session will be moderated by Dr. Orko Prabhu Rai, who is a associate professor of surgery at Calcutta Medical College. The first presenter will be Sritama. She is from PLS Hospital. So Sritama, I think she's from Ruby. Yeah. So Sritama, you can share your screen and start presenting. Sritama, you are not audible and screen is not visible.
Sir, she is trying to connect. She's having a slight connectivity issue.
Okay.
Hello.
Yes.
Good morning, respected faculties. Actually, there's a slight problem. I haven't reached the hospital yet, and I'm still on the road, so there'll be some audio issues. If it's okay with you. Hello.
You are audible. You can start.
Okay, sir. So my topic was enhanced recovery after surgery in individuals with diabetes, systematic review. I am Dr. Sritama Roy, first year DNB resident in general surgery from Ruby General Hospital. The background of this study includes the following. This review is about diabetes. So diabetes is one of the most prevalent diseases in India. It is a chronic disease with worldwide prevalence of 7.2 to 11.4%. The ERAS protocol has a large number of surgery. The ERAS protocol basically studied the effect of implementing the protocol in patients with diabetes to see if there is any change in postoperative implications or postoperative length of stay in hospital in patients compared to the general population. So here we have there is a lot of surgical interventions that are taken up by diabetic patients, and diabetic patients have a higher prevalence of perioperative morbidity and mortality. They have an increased length of stay in the hospitals, and there's a higher number of healthcare resource utilization by them, because for diabetic patients, we need extra monitoring of daily checkup of glucose, daily insulin, and a lot of other resources that are more compared to the general population. So what is the ERAS protocol? ERAS protocol basically stands for Enhanced Recovery After Surgery. It is an evidence-based multimodal surgical care pathway. There are three different factors that are included in ERAS, that is preoperative, intraoperative, and postoperative. And there are total 22 factors that constitute the ERAS protocol. ERAS protocol shows that in general population, they reduce the length of stay in hospital by 30%. Postoperative complications in patients who follow the ERAS protocol decrease by at least 50%. It includes 22 parameters in the sections of pre, intra, and postoperative care. All strong recommendations according to GRADE, that is Grading of Recommendation Assessment, Development and Evaluation Framework. They are the ones who have recommended which 22 factors will be taken in the protocol. And this was published in the year 2005 and it was last updated in the year 2012. So, diabetes. Is it a good thing or is it a bad outcome for patients? So there are certain factors that are different in patients with diabetes. That is, if we implement the ERAS protocol, one of the preoperative factors that should be included is a carbohydrate loading. Carbohydrate loading is done according to ERAS protocol in all patients, in all surgical patients, preoperative. So if it is included in diabetic patients, there is a risk of delayed gastric emptying, which is more than gastric emptying after more than 180 minutes. And this can lead to aspiration pneumonia. And also hyperglycemia is a problem with diabetic patients who are on insulin or who are not or oral anti-diabetic drugs. So hyperglycemia and its sequelae is an also important thing to note. Chronically elevated glucose, how is it affecting diabetic patients? There is autonomic neuropathy and intrinsic nervous system dysfunction in multiple cellular targets, which includes the neurons which produce nitric oxide, interstitial cells of Cajal, and the gut hormone levels, which are also disturbed by the chronically elevated glucose. Those affected have a deranged proximal gastric accommodation and contraction post solid meals, and they reduce the number of antral contributions. And postoperative complications in hyperglycemic patients are generally high because chronic elevated glucose invite more number of infections in the body, and they increase the time of wound healing. What does acute hyperglycemia do? Acute hyperglycemia is acutely elevated glucose more than 11.1 millimole per liter. It affects delayed gastric emptying, and raised glucose decreases stomach and bowel contractility, and it also stimulates localized pyloric contractions. And as we have seen in chronically elevated glucose, acute hyperglycemia also results in... Sorry, sir? Hello?
Shitama, continue. You can continue.
Yes, sir. Okay.
Carry on.
Okay. Acute hyperglycemia also increases the number of postoperative complications. Okay. So what is the method that is implemented in this study? So they have taken a large number of randomized controlled trials, subgroups of randomized controlled trials in individuals who have undergone elective surgery, and they have also taken non-randomized studies, which has a more robust methodology, and it includes the non-randomized controlled trials, control before after or CBA studies, and interrupted time studies, along with cohort studies with concurrent controls. So the intervention has consisted of all 22 elements existing in the ERAS and all the non-ERAS protocols, which includes a lot of fast-track protocols, ERPs, that is the Enhanced Recovery Program, have been eliminated from this due to lack of any standardization. What are the type of outcome measures that we have taken? Primary outcome that has been taken is the measurement of length of stay in the hospital. And secondary outcome are three postoperative complications, 30-day readmission and complication rates, and episodes of hyperglycemia, that is glucose more than 14 millimole per liter, preoperatively or postoperatively. What are the search methods that we have taken? They have included electronic searches where they have the randomized trials and the non-randomized trials, and other resources include conference proceedings of surgical and anesthesiology societies, bibliographies of review articles, and trials of identified studies that have been accepted. Okay, so now we move on to the total number of protocols, elements of the ERAS protocol. Operative stage includes preoperative, intra, and postoperative. So preoperative elements include pre-admission counseling, fluid and carbohydrate loading, no prolonged fasting, no selective bowel preparation, antibiotic prophylaxis, and thromboprophylaxis, along with no pre-medication. The intraoperative factors include short-acting anesthetic agents that are used, mid-thoracic epidural anesthesia or analgesia, no intervention with drains, avoidance of salt and water overload, maintenance of normothermia. So post-operative factors include the mid-thoracic epidural analgesia or anesthesia, no NG tubes, prevention of any nausea and vomiting post-op, avoidance of salt and water overload, easy removal of catheter, early oral nutrition, non-opioid oral analgesia or NSAIDs, early mobilization, stimulation of gut motility, and audit of the surgical procedure. Results. So the results we have got is out of 437 electronic search references, 376 were eligible after removing the duplicates. Bibliographies of reviews, conference proceedings, and ERAS guidelines provided 8 more searches. Searching the clinical trials website, we have yielded 59 references and 14 full articles were retrieved and subsequently excluded as they used other interventions that did not include patients with diabetes, or they have been used in uncontrolled before-after design. So the discussion includes what have we seen in this study and what are the things that we can contribute here. The review here did not identify any RCTs or observational studies meeting the EPOC criteria. EPOC is Cochrane Effective Practice of Organization of Care criteria and evaluating the effects of ERAS in diabetic patients. This is the first ever systematic review in our knowledge that addresses this question, whether diabetes is a good subject for implementing the ERAS protocol. There is still a question remaining whether diabetic patients will have improvement in care if they have been enrolled in ERAS and experienced in patients without diabetes, or whether the potential risks involved with hyperglycemia and with carbohydrate loading would actually negate the positive factors. Okay, so if implementing ERAS and monitoring adherence would be cost effective in patients with diabetes is also a question, because ERAS implementation already includes a lot of factors that we have to check pre-operative and post-operative. Adherence is important in diabetes because if diabetic patients do not comply with their medicinal routine regularly, it will affect their blood glucose, it will affect their gastric emptying. That will lead to a lot of other negative implications, and that would mean that they will utilize more hospital resources. And the only study using ERAS was Luther and colleagues, where they analyzed 18 patients in the diabetic group, 125 patients in the non-diabetic group, and they have been both scheduled to undergo colorectal surgeries. In the median length of stay in the diabetic group was 7 days, with a quartile range of 5 to 15.5 days. And in the non-diabetic group, it was 5 days with a quartile range of 4 to 7.5 days. With a p-value of 0.041, it is unknown whether the results are found to be different in the diabetic group outside of ERAS implementations. And that is why, due to lack of standardization, again, this study was excluded from the review. Effect of liquid carbohydrate loading for implementing the ERAS protocol. The results suggest that harm is unlikely given a complete gastric emptying in less than 180 minutes. So there are two studies that we have read about in this systematic review who have studied how liquid carbohydrate loading affects the diabetic patients if ERAS protocol is implemented. So a study by Jones et al. Showed that administering 15 grams of dextrose containing drink to subjects with variable diabetes control who have a median HbA1c of 9.3% had no delay in gastric emptying in about 72% of the patients. Another study by Gustafson and colleagues used drinks containing 50 grams of dextrose in a 50 grams of glucose in a better control group of diabetes with the HbA1c of 5.6 in people with insulin control and 6.8 in oral hypoglycemic, and they had no signs of delayed gastric emptying. The ERAS care system was tested in 40 hospitals across Europe and North America. Controversy still exists on the effective use of all ERAS components needed to impact a positive postoperative outcome. There are recent studies with ERAS which show that it has a positive impact on laparoscopic surgery independently, but this is not specifically with diabetes. It has also shown promising results in 5-year cancer-specific survival after post-colorectal cancer surgery, which is stark contrast to any other fast-track recovery program. So finally, ERAS hasn't shown any significant impact on the postoperative care of diabetic patients. Case-on-case basis examination is needed to understand its impact on such cases. Specific guidelines in terms of diabetes type 1 and 2 are prescribed in Jocelyn et al. For capacity of food intake through the mouth. For subjects with type 1 diabetes, the following non-randomized studies, non-randomized control trials, case-based control before after, and ITS, that is forgot the full form. ITS has been recognized as most effective. To conclude, a policy change in ERAS implementation for diabetes patients is suggested for further detailed understanding of its effectiveness in patients with diabetes. So basically, ERAS protocol has a very limited number of studies with diabetic patients. There has been no standardization in if we compare with the diabetics and non-diabetics, and both with an ERAS protocol implementation. There has been very less number of studies that have actually studied the carbohydrate loading impacts, and also the gastric delay that will actually affect with aspiration pneumonia and other implications post-operatively. So these are the things that we have gained from this study, sir. Revisiting the clinical significance of gastroparesis preoperatively in individuals with diabetes. Main potential barriers of carbohydrate loading, not a very common sequelae as previously thought. A population-based study by Chaum, RS et al. Found a cumulative incidence of 1% in patients with type 2 diabetes versus 0.2 in controls. A large population-based study by Camilleri M et al. Found incidence of gastroparesis in 5 to 12% in patients with diabetes only. And Parkman HP et al. Studied that gastroparesis was in fact idiopathic over 1 to 1/3 of individuals. The reason that we have included this information here is because ERAS protocol does not really talk about the postoperative implications in these patients, and gastroparesis is something that is affected by delay. It is a post-op effect of delayed gastric emptying, not the effect of ERAS in gastroparesis. And I think this is the last slide, Milind, Dr. Milind.
Yes, this is the last slide.
Yes, sir. So, thank you.
Dr. Orko, you can discuss some
Yes,
part.
so Dr. Sritoma, there are three things when we actually plan for a journal club. Regarding the journal,
Yes, sir.
we take up the journal thinking that if there is anything new in it, and whether it was at all indicated for a journal club or not. Number two, if it is anything new in it, then what is the rationale of doing that, and whether it can be implicated in our regular practice. And number three, the institute or the individual who is carrying the journal club, whether there is any change in his or her approach after that in treating diabetic patients. So from your study, it has already been mentioned, yes, there is very limited data or limited evidences regarding the ERAS protocol for diabetic patients. Though the ERAS protocol is not for this disease-specific group, it was from a surgical point of view, that's colorectal surgery or neurosurgery, whether that protocol can be instituted or not. It is not like that it is for hypertensive patients or it is diabetic patients. So ERAS protocol is for the particular type of surgeries, mainly for GI surgeries and colorectal surgeries, which was first instituted, whether that can be taken care of, that the things that stay in the hospital, early recovery can be promoted. So now that your this journal has already mentioned that yes, there is a very limited number of studies. It is also told us that yes, there is many areas to improve in case of ERAS protocol regarding diabetic patients. But I want to know whether you are actually practicing what you are just told or mentioned in this journal club in your regular practice in your hospital.
Sir, actually, in our hospital, we sorry, sir, am I audible, sir?
Yes.
Okay. So in our hospital, sir, we have not all surgeons. Actually, it is surgeon to surgeon basis. In colorectal surgeries, we generally have very comorbid patients, and we have not really practiced the ERAS protocol on them, and even most of them include diabetic patients who have colorectal malignancies or colorectal obstruction. And we have not, none of us have still, like in my 6-month tenure here, I haven't noticed any ERAS protocol implemented in colorectal surgery patients. And in laparoscopic surgery patients, sir, we have been like using the ERAS protocol quite effectively. But no, I don't think that all 22 elements of the ERAS protocol have been implemented. Like carbohydrate loading and all of this, we have not done in any of the patients. So, sir, I don't think we have yet started it here.
And another question regarding this study. So what is the criteria for maintaining strict glycemic control, which is a part of treating a diabetic patient in pre and post-operatively, and also the value of HbA1c? Whether you can highlight anything regarding this. These two things are mainly important in case of
Sir, your audio is disturbed, sir.
If glycemic control is not strict glycemic control, and value of HbA1c is important in out.
So I think you're asking the criteria of maintaining strict glycemic control, sir.
Yes, and HbA1c value.
Okay.
Because one point it showed 9.3 as HbA1c.
Yes, sir. What is
the 9.3 indicates this is a poorly controlled diabetic.
Yes, sir. So criteria of me. Sir, if HbA1c is in the range of 5.5 to 7, then it's a well-maintained diabetic, sir.
Yes.
And so, sorry, what other question? I did not get the question. the other question.
Actually, in another point I was finding, you
Yes,
said
yes.
that some of the studies included the readmission rates. I could not find out from your presentation what was the readmission rates for these patients for in view of hyperglycemia, or because that is one of the important aspect of success of ERAS protocol, that you are
Yes.
discharging the patient and what percentage of patient is being readmitted. I did not find that slide, that what is the
No, sir,
readmission rate.
not include that. I think I
Well, you
missed
see,
it
if you
out.
say the average stay is 5 to 7 days,
Yes, sir.
that by stay criteria, that does not fall in the ERAS protocol. ERAS protocol is a discharge of the patient from 24 to 72 hours. So
Yes, sir.
staying for 5 to 7 days, the day-wise ERAS protocol, you can follow these different components of ERAS protocol, but the idea was to discharge the patient early.
Yes, yes, yes.
Is there any points to say that in this number of studies, how many was the readmission rate, whether it is different for diabetics? Because in most of the ERAS studies, diabetes patients are not excluded.
Okay.
Because I did not find that slide. Outcome, you said the main study pattern was outcome of these patients.
Good morning, sir. I mean, Dr. Sumanta here, sir.
Yes, yes.
Sir, I have gone through the article, so I have seen Sitama's presentation. Just to add some points.
Yes, yes.
According to this review article, meta-analysis, what they said is none of the 443 studies have followed the ERAS protocol. So they have not included any studies. Actually, they said that ERAS protocol has not been followed in any of the studies. So they excluded all the studies. And they say that as the ERAS, it is not that ERAS protocol is properly implemented or some modification is required in ERAS protocol, because if all the 22 points are not followed, then it is they have not included that study into that protocol. So they say like we need more randomized control trials following all the 22 points in future. So that's why maybe they have, as they excluded all the studies, that's why they have not mentioned any of the data of those studies, which is
then the point is that ERAS protocol being applied to diabetic patient does not stand in this review article.
Right, sir.
They're trying to study whether this diabetes is a group of patients where ERAS will be applied or not, and what is the previous study says. So they could not find that all the protocols are followed.
That's why they have not included any of the studies, and they said in future we need more studies following only strictly following the ERAS protocol, mainly randomized control trial, and in some cases some non-randomized control trials, and in some case series, a broad case series. So they said like in diabetic patients, it is not. I mean, it cannot be concluded whether ERAS protocol can be followed or not. That is the main conclusion of this study. What I understood is actually.
And one reason they're saying that the incidence of gastroparesis might be high in diabetics.
Yeah.
And that is one reason that you see, you discharge a patient, there are important criteria for patient getting discharged from the hospital ERAS protocol. One is patient should be pain-free, patient should be ambulant, and patient should be taking oral feeds. So if the patient has got prolonged gastroparesis, the oral feeding will not be possible. So that is the point. If you apply this protocol and then study this population, how many are getting readmitted for vomiting or prolonged gastroparesis?
So on the other hand, on the contrary, they have said that in initial period, like in around early 2000, what studies they said like it is almost 50% that the patient may suffer gastroparesis. But later, some studies came up that, as Ritama mentioned, that only it is not that high. The incidence of gastroparesis in diabetic patients is not that high. It is around 5 to 12% in most of the study, and even less than that. So that what we are fearing that if we apply ERAS protocol, if we do carbohydrate loading in diabetic patients, patient may vomit or can aspirate and can form aspiration anemia and pneumonia, aspiration pneumonia. So it is maybe not that true. And that's why they are suggesting that we should do ERAS protocol in diabetic patient to see the outcome. So gastroparesis, according to them, is not that prevalent in diabetic patients like it was in initial studies, like 50% or 40%. It is less than that. So they said if we can select patients accordingly, well-controlled diabetic, HB1C more than, less than 8 or around 7, and if we follow the sliding scale and maintain the post-operative blood sugar level between 80 to 180, then we can assess the effect of ERAS protocol in diabetic patient properly.
Dr. Orko, you're online?
Yes, sir.
Yeah. We pass on to the next topic?
Yes, we can.
The next will be presented by Dr. Srija Rai from PLS Hospital. So, outcome of mini appendectomy patient. Srija, you can share your screen. Srija, you can unmute.
Dr. Srija, you're not audible. Please unmute.
Give the first slide.
So she's on.
Oh, she's.
Yeah, you're still not audible, Dr. Srija. Can you please check your audio?
Srija, you are seen, but your audio is not clear. Check your audio. Come to the first slide. Audio नहीं है.
Srija, you're visible also, but we can't hear you. Are you connected to some device? Are you connected to some speaker? So your slides are also visible, but there is only an audio issue.
Srija, you can sort your audio problem. Yes,
hello.
you're audible, but take it first connection off.
So that is for the laptop.
Okay.
Dr. Srija, you can speak from your phone and let the presentation play with the laptop.
Okay. Thank you, sir.
And just keep your laptop on mute. Just keep that the laptop audio on mute. And let the phone audio be on. Yeah.
Okay. Now it's okay, sir?
Yeah.
Yes.
Thank you so much. Good morning, everyone. I'm Dr. Srija Roy, JR1, Peerless Hospital and Bikaroy Research Center. I'd like to present a case of, I'd like to present an experience of 150 cases of outcomes of mini appendectomy in a tertiary care hospital of Nepal. This study was done by Dr. Pooja Chaurasia, Dr. Jatindranath Bhagavati, Dr. Ashok Koirala, and Dr. Gambhir Shrestha, and it was published in Indian Journal of Surgery in June 21. The publisher of the journal is Association of Surgeons of India. So to introduce, acute appendicitis features a common surgical emergency. The surgical scar is the only component patients notice and perceive as the only outcome of surgery, apart from getting relief from the symptoms. This has encouraged surgeons to use a variety of incisions for abdominal visceral surgery that are concealed from exposure. Mini appendectomy is miniature incision of 1.5 to 2.5 centimeter gridiron incision at McBurney's point in patients of appendicitis and has shown to be effective in different countries and different settings. The operative procedure for mini appendectomy requires preoperative preparation, anesthesia, and simple instruments that are cheap and can be easily procured, similar to traditional open appendectomy. Thus, mini appendectomy can be performed in a resource-limited part of any country, in contrast to other procedures like laparoscopic appendectomy, which requires sophisticated instruments. This study aimed to assess the perioperative outcome of mini appendectomy. Aim of the study was to study the outcome of mini appendectomy. The criteria were length of incision, operative time, incision extension, analgesics usage, hospital stay, return to routine, satisfaction with the scar, complications, and perioperative findings. Materials and methods. The study design is descriptive cross-sectional study. Study site is Nobel Medical College and Teaching Hospital in Nepal. Methodology, convenience sampling was done. Data were collected using a proforma. Discharge criteria included patients oriented to time, place, and person with stable vitals, tolerated oral fluid, passed urine, adequate pain control, could ambulate, and had no on-site complaints. All the patients were followed up at 1 week, 1 month, and 3 months. Patient subjective scar satisfaction was noted as yes or no. The patients admitted with diagnosis of acute appendicitis who underwent mini appendectomy from August 2006 to August 2017, 2016 to 2017 were included in the study. Whereas patients with body mass index more than 25 kg per meter square and patients with appendicular lump or perforation or abscess were excluded. The perioperative management in mini appendectomy included routine groundwork of surgery like that of appendectomy surgery. The operation room setup and patient position were analogous to that of a conventional open appendectomy. Preoperatively, single dose of 1 gram ceftriaxone was administered intravenously. Surgery was carried out under general or spinal anesthesia. Operative time was defined in the study as the time interval between incision made and completion of wound closure. Postoperatively, 1 dose of IV analgesic was given 6 hours after shifting from recovery room. Mini appendectomy was carried out by classical gridiron incision made at the right angle to the line joining the anterior superior iliac spine and umbilicus with its center at McBurney's point, measuring 1.5 to 2.5 centimeter with the scales. The operation was carried out with a no-touch technique by or under supervision of senior surgeons. External oblique was incised along the line of skin incision. Then internal oblique and transversus abdominis fibers were split and retracted on each side. Peritoneum was lifted between two hemostats and checked to see whether underlying bowel had been lifted. Peritoneum was incised and opened. Then wound was well retracted. Appendix was identified and brought outside the incision. And formal appendectomy was done. Parstin suture was applied in the wall of the cecum to bury the appendix stumps in majority of cases. Thereafter, abdomen was closed in layers. The sample size was calculated considering 96% success rate in mini appendectomy, which was one of the most important perioperative outcome in another study by Sashin and Dhar. The sample size calculation was calculated by the sample size formula, sample size 4PQ by L square, and the sample size was 125. However, all cases from August 2016 to August 2017 undergoing mini appendectomy were included in the study. The data was entered in Microsoft Excel and analysis was performed on SPSS version 20. Proper ethics approval was taken and written informed consent was obtained from all participants. Now for result, length of incision was 1.5 centimeter in 95.3% patients. It was 1.6 to 2.5 centimeter in 4 patients, that is 2.7%, and it needed to be extended up to 4 centimeter in 3 patients, that is 2%. Intraoperative findings, in most of the patients, they found inflamed appendix, that is in 78% patients. In 2.7% patients, they found gangrenous appendix. In 1.3% perforated appendix, and in 18% of patients, subtutive appendix. The periappendiceal collection was found in 100 patients. The patient, mostly the patient needed to be NPO status for 6 hours, that is 94.7%. Others needed to be kept NPO 8 hours in 6 patients and 10 hours in only 2 patients. For requirement of IV fluid and electrolytes, most of them required for 24 hours. However, 40 patients, in 40 patients, IV fluid and electrolytes for 12 hours was sufficient. Average operating time was 16.67 minutes. For post-operative additional requirement of analgesics, it was required by only few patients. 4 patients required 1 dose IV and 2 doses of oral analgesic. 1 patient required 1 dose IV analgesic and 1 patient required 1 dose of oral analgesic as additional doses. Post-operatively, most patients could ambulate in 6 hours. That is 145 patients, about 96.7%. 4 patients in 8 hours and 1 patient in 10 hours. The average time in which patient could ambulate was 6 hours. Hospital stay was less than 12 hours in 40 patients, 12 to 24 hours in 70 patients, 24 to 48 hours in 30 patients, and 48 to 72 hours in 10 patients. The mean hospital stay was 28.8 hours. As per complication, 2 patients presented with wound infection on the 7th day of follow-up. A majority of patients was satisfied with the operation. To resume the normal work, most of the patients could resume the work within 7 days. That is 96% of patients. 2% of patients could resume work in 8 days, 1.3% in 9 days, and 0.7% in 10 days. The average time required for the patients to resume their work was 7.07 days. So to conclude, mini appendectomy is a simple operation enabling less operative time, conversion rate, and need for analgesia. This study reflects minimum post-operative pain, less hospital stays, early return to the routine work, and fewer post-operative complications. Thus, mini appendectomy is a promising minimally invasive procedure for the cure of appendicitis and also provides maximum satisfaction to the patients. Thank you, everyone.
Dr. Rai. Dr. Arko, discussion on this? Actually, I was one of the proponents of mini appendectomy, but I find this paper as very brilliant paper with all the outcomes. But if you go to the practical field of doing a mini appendectomy, it's not a very easy job. It's a very difficult job, needs a lot of retraction, particularly if the appendix is retrocecal. This only you can achieve. You see, 1.5 centimeter incision, in the majority they could achieve that, is if it's only a mobile appendix. Appendix is lying free. That is a situation you can bring this appendix out through this such small incision. It is difficult to bring out the terminal lobe of the ileum. It is difficult to bring the cecum out through this incision. Only the appendix tip to base can be delivered through this incision. It's a very difficult, it's not that easy. I can find that the paper shows all the brilliant performance, and the average time was 16 minutes. Is again difficult to achieve, I feel. And with advent of laparoscopy, once you have the facility, you just see the other advantage of laparoscopy. That is a good diagnosis. Sometimes diagnosis is also not, if you say 150 cases, there will be some situations that diagnosis is not correct. So in that case, a mini appendectomy may not be an alternative to laparoscopic appendectomy. Okay. So Dr. Rai, any comment? Dr. Shuvanta, any comment on it from your side?
Sir, absolutely, whatever you said is absolutely correct. And one more thing, it's the position of the appendix can vary. Like you said, it can be retrocecal, pre-ILA, post-ILA. Even some situations, cecum is high up and the appendix is retrocecal subhepatic position. So in that case, if you start from McBurney's incision with just 1.5 centimeter or 2 centimeter incision, you cannot achieve up to subhepatic position. So in that situation, it's very difficult. Again, if it is a complicated appendicitis, it's very difficult to see the rest of the, around the appendix, the cecum and the terminal ileum. If it is fixed with the retroperitoneum, then it is difficult to explore. So I think in my practice, after reading this article, even I have not changed to my practice to mini appendectomy. I'll still go for the laparoscopic appendectomy for better visualization and adjustment of the ports and techniques depending upon the position of the appendix, type of the appendix, and inflammatory features, or if there is any associated pathology, we can easily identify with laparoscopy.
Yeah, the point they made out is if you have don't have the facility for a laparoscopy appendectomy, then you can attempt in doing a mini appendix. But point is, they are showing some gangrenous appendicitis and 2 cases of appendicular perforation. It is very difficult to manage with such small incision. It is very difficult to achieve the desired result, because if you need to extend, even extension to 4 centimeter may not be adequate.
Yeah, adequate. Yeah, right, absolutely. And even
and you see that discharge criteria. Most of the patient, more than almost 80% patients are discharged in less than 12 hours time. It's very difficult to achieve in our setup. You see, our patient who are being operated, everybody is, there will be some stitch. There will be 1 or 2 stitch. So our people who are being operated, unless the stitch is off and he is not agreeable to join his normal duties, it's very difficult to convince this patient they go and back to their work in about 3 or 4 days time. It is very difficult to achieve.
Right. Again, sir, if there is any appendicular perforation, abscess formation, it's very difficult to give lavage, peritoneal lavage with that small incision.
It's not possible. With this small incision, you cannot give lavage. It's not possible. Right. Maybe that the perforation cases they have extended. It's not clear. But point is, to achieve such a result will be difficult for any other group. I am sure that all the operations done by senior consultant. It's not the job of a resident to go on with a 1.5 or 2 cm incision for doing appendectomy. It's very difficult.
Sir, would you recommend your trainees to practice such kind of operation?
Even for gallbladder, I don't recommend I make my resident do a cholecystectomy. I don't teach them do a mini cholecystectomy. I give a standard incision, let them learn the standard incision and open cholecystectomy, and same with appendix. Once you have sufficient experience, you go on to the level of senior resident, and yes, you try doing this these procedures. I don't think in resident level one should start practicing doing mini cholecystectomy or mini appendectomy.
So very true.
Dr. Orko, any comment? Situma, they have mentioned about the seizure. They have mentioned any criteria for discharge, because somebody is getting discharged 12 hours, somebody is 24 hours. What are the criteria for discharge? Why are some patient held up? Any explanation for that? Srija?
Yes, sir. They have mentioned some criteria for discharge. The criteria for discharge was the patient. Sorry.
You are not audible.
Srija, you're mute again.
Yeah, criteria for discharge is what? Because you say the analgesic requirement is also much less. But my experience is the analgesic requirement is more for these patients, because you need a lot of retraction. And this retraction and stretching causes post-op pain. Not all patients are relieved with 1 dose of analgesics. Dr. Orko, please.
So their discharge criteria including patients oriented to time, place, and person with stable vitals, tolerated oral fluids, fast urine, and adequate pain control was there. They could ambulate.
Yeah. So standard discharge criteria. Agreed. But it is, why was some patient being held up? Means these patients are not, because I can find the majority are being discharged within 12 hours.
And had no on-site complaints. At this situation, they discharged the patients.
No on-site complaint comes up in 12 hours time. If you operated this patient, no on-site complaint come in 12 hours or 24 hours time. Most of the on-site complaint comes beyond that period of time, maybe a infection or whatever. So no complications comes in 12 hours or 24 hours time. So the standard discharge criteria. But my point was maybe that they have mentioned some patient of appendicular perforation or gangrenous appendix. Maybe that those are the patients who are observed little more period of time. Because you see, 12 hours is difficult to achieve. If you operate a patient morning 10 o'clock, you cannot discharge the patient at home by 11 o'clock or 12 o'clock at night. So this criteria of discharge by 12 hours is not a very valid criteria, I feel. Dr. Orko, any comment? Or you can... I think Orko has some audio issues.
In case of perforated appendix or gangrenous appendix, you should wait more. for discharge.
Yes, yes, might be.
In case of gangrenous and perforated appendix, you should wait more to discharge the patient.
But they have no readmission. They have the few cases they have mentioned. They have no readmission rates.
Yes. Thank you, sir.
Okay. Okay. Thank you, Srija. Thank you, Sitama. Thank you, Dr. De. Thanks for joining. Thank you.
Thank you, sir.